Okay. Oh, like that, you know. 그러면 ECG conference. Okay. Oh, that's the point. Okay. 네, 갑시다. 네, 시작했습니다. Good morning, everybody. We're going to start the ECG conference, July 17th. Yeah, CLBT conference, you know. I'm going to present today ECG. I got to share with Dr. Callahan, who was the fellow at the University years ago. They have an interesting case. This is the EKG he shows to me. I'll look at it for a minute. Let's go on. Where's part first? And give them that to read it. So that. You elected number one, okay? Go. You need the pointer, and ready there. You point it to us. What are you telling us?
The heart rate written is irregular, heart rate is around between the 100 to 80 to 120, and there is every quartz complex is not perceived by P wave, and there is a wide and narrow quartz complex.
So how many different complex do you see? First complex, how many different types?
Or more than
Many. So about 4 to 5, right? First complex. Next is, what is the lithium do? Do you see P wave anyway? Show it first. There's the P waves, but there's interactivity, right? Yeah. Next, we need to look at what is the P wave axis. Can you tell us what the P wave axis is, this patient? So first, probably the 2, 3 ABI, right? 1, 2, 3, right? So that would define your sinus rhythm. Look at the last complex, very last complex. You see this P wave, right? So always try to look at when you see complex arrhythmia, whether interactivity and P wave axis is normal, abnormal. And then you trace back whether all the P waves look the same or not. It would be easier. So trace back from that last bit. What do you see? PP interval is regular, right?
Yes.
Yet may not be, maybe associated with QRS complex, right? Very last complex. What do you think? That's a normal rhythm or not? Yeah, well, yeah. Most likely it is. Then that's your recurrence now, right? So let's trace back to what the PP interval looks like. You can do that, okay? Because the last 3 complexes we seem to P with. Last 3 complex. Then you measure that with the caliber, multiple back. So you can see previous complex has a wider complex followed by P wave, and then related to the narrow one that has apparently no P wave, and then long pulse in the P wave end of the first complex. So bottom line, it is mostly dissociated, associated.
Dissociation.
You think it is associated or intermittent capture rate? That means associate. So you have a both pattern here, associated and associated. Okay, that's why it's so complex looks like. Now, we need to know P and QRS relationship. What interval that they change the QRS morphology. So now you know what's a P wave looks like. Let's come back to the first complex. Well, I mean, first wide one, right at the left panel. The first one. Yeah, that one. What's the P wave, that one? Why after the QRS complex?
All through the parameters.
Okay. Correct. Talking about, this guy. Then, right? So then that looks like a conductor next QRS complex, you think?
No more first.
So do you think that this complex here, this guy conducted here? What do you think? If this was conducted normally, would be narrower, looks like that. But if you imagine this guy, this last guy, mixed the white guy, wouldn't be a fusion here? So you got probably maybe questionably long PR with the fusion with the PVC has to be on time. Now you know what's if it is a fusion, then you know what's the ventricular rate is because this is the R. This is a fusion, right? So this is a sinus rate going on. Also here. So you have what kind of interaction here? How many different rhythm? One or two or three? What do you say? Now let's just think for one. So it has to be ventricular rhythm going on simultaneously for the atrial tachycardia going on. With the atrial tachycardia here the axis could be normal, may not be sinus, okay? But it looks sinus.
But if you look at their cross complex 7 and 8, the PLA will change.
Yes,
Long and
right there. This one you're talking?
No. Left side.
Left side, this one?
Yes.
Okay, yes. And what does that mean? This PR change, this is the longer, you say this is shorter, what you're saying? It's still could be conducting because of your AV nodal. AV
I
is the
saw
meaning
that.
of fusion.
Similar pattern at the end.
And
the
right.
lattice repeat.
Yeah. So if you assume this is a patient's normal rhythm, obviously patient does not have a normal QRF, normal EKG, this is like normal. But if you're saying that this is captured here, maybe this conducted here, but a little bit more fusion than that, that's pure sinus. And then you got another narrow, and then the wider one, which is clearly, I don't think it's a conductor because of there's a P here, but it become wider. Question, this is the aberrancy, or this is a ventricular rhythm? That will be the no, because of your relationship. So what you're saying, right? There's another P here, over here, and then you got a longer PR. So, fact is that this is a longer PR. This is probably ventricular rhythm because the reticularity concealed the node and then cause the first VP flat. Okay. So this is what we call reticularity concealment of PVC to the AV node because this is not conducted to P PR. Make sense or not? So I want you to go read the book today. Josephson chapter called Concealed Fusion Facilitation, and he describes 7 different of excitable gas. This is one of the remarkable EKG that I saw, many examples of excitable gas. That's why I brought this ECG for you to interpret. Okay, so PVC morphology, you have 2 different ones as well. Here and here, they're different, they're not same, right? So if you have this complex here, so you watch carefully, this PR is even longer than other. Okay? So you need to look at this. So when you see this such complex arrhythmia EKG, you need to be characterizing P wave first, and then try to find a normal EKG as possible, and then you march through back. Let's take a look at the next slide. Okay, now let's QRS complex. Only every other beat. Okay? Now it's clear, you can see better. Okay? Yes,
So. Can I see the previous?
okay, let's go, previous right here.
Yeah,
Sir.
so, we can explain the why if we look at the narrow pulse complex. First, the tail interval long.
Right.
and Next one is normal.
Right.
Maybe because of the PVC made the retrograde concealment.
Concealment, yes. Peel back phenomenon.
Please. Explain about the retrograde concealment. It is concealment. Very possible, yes.
You got the guy now.
I should have read the chapter.
It is a real.
Oh, he was too hard to read. You can read about it. It is important concept. The reason I put this EKG on, was the professor on. He sent me an EKG of his case. He asked me, what's the mechanism of this? Remember the tracing you sent me? Yeah. So he did a bunch of ablation and patient, and I think it wasn't, he didn't have intracardiac signal, but then the patient had a long PR. Had the PVC, subsequent P came shorter. So he asked me, what's the mechanism? So that is similar to this mostly. Okay. So NET tracings, you're gonna see many of these. So you need to know really well about the gap phenomenon. The Josephson chapter. Okay, each got 7 different one. There's one that missing on this chapter is whether you believe or not, supernormal conduction. Some EP senior members, they do believe supernormal conduction, some people don't believe. Okay, it's very hot debatable, but none of them did the intracardiac measurement of supernormal conduction patient, so we don't know exactly. Okay, so but why did they accept it as 7 different mechanisms? Okay,
I have a question for you.
yes, sir.
Have you ever experienced the retrograde concealment block only the fast pathway and make a PR stop?
Well, again, I don't think we can answer that question because we cannot measure separately fast pathway potential versus slow pathway potential, especially. We only know by interval deductive. We don't have a fast pathway potential per se. Similarly, not having nodal potential, maybe not the conventional. So that would be a wonderful demonstration mechanisms, but I don't think I'm not aware anyone done that. Yeah, even high density mapping area, I don't think they done that. Yeah. Now we do know there's for example, tachycardia that originated near the fast pathway. And only just atrial tachycardia by B patient, not A patient, by source mismatch, but then that's very rare. Yeah, I've seen only handful of cases, 3 or 4 cases. The last case I saw was in the about last month of Sejong, there's one patient who ended up breaking the A block and no tachycardia, maybe because that's was wrong. So we know the fact of that, but it's all by deduction, no. Really. So let's go forward anyway. This is a EKG, and then they gave another on this patient. What happened here? Pretty similar mechanism, right? Just to have occasional what? This guy here. Tell me what's happening here. The one you might read, oh, this is junctional tachycardia or whatever, but you read it carefully.
Talking about the problem of time.
So you see a keyword clearly, right? Same thing, same exercise. Very last week, you will have normal sinus capture view effect, right? Yeah. Asian cases are grossly abnormal, certainly, no question about, but then we're just looking at the rhythm.
I think the E6 is most easy to see
Right.
the P wave
Yes.
marching through among the towards breast.
The question is the keyword, did dissociate or associate? That would be the question. Now, why do we have some occasional shorter right interval there? What is the mechanism of that? That would give you an answer.
Looks like isoarrhythmic AV dissociation, but the most isoarrhythmic ALVL is very slow with them. This is very cardiac condition.
Very sick patient.
Yeah,
This is.
QAVs. I mean,
Patient-
earlier and later than first.
Patient essentially, quick looking at him, patient got global heart disease. Got ventricular ATM as well. Very sick. You can see, P wave coming in and out of it. That's it. So it's hard to know whether this would be truly some sort of tachycardia going on, okay, on PC, or this is a isolated association impact positive. So regardless, this is the very sick patient came. Then what we did, they gave amiodarone. Okay, what happened? Now, patient developed what? You got this, oh, sorry. Patient, you got this rhythm here going on, and then you see, okay, you know, this bit, this bit, this bit, this bit. You know what this is? This is sinus capture beat. So amiodarone, wipe out her sinus one. Patient is just junction on it, mostly. Okay. Then cardioverse. Patient got so sick. Look, this is sinus. Now you can read the ECG for me. Who is going to read the ECG? So patient is what? First P wave by turn large now, right? How do we know that? Tell us. You got double hump, tall P, so first the right atrium, second the left loop. Then you can see notching. And then what else? Patient has QRS duration criteria for what? Patient has the left ventricular hypertrophy or not? Yes, does.
Yes.
The patient have any evidence that patient does the right ventricular hypertrophy? Let me ask that question. Yes or no? Why am I asking that question? Look at the T wave inversion interior 3, ADF. What is that? The strain pattern, the right ventricle. This patient has a biventricular enlargement, biatrial enlargement. So global heart disease. Okay. Well,
The
then,
inferior T version could be by LV left ventricle.
it's V2, but then it's fluid different. Now what you think? Okay, this is amiodarone oral therapy. Patient continue to have a 6-9 syndrome, all this trouble. So they end up stopping amiodarone. Okay, it's normal, like the junction rate is slower, but then still dissociated, not working as well as it'd like to be. She's a 20-year-old female. That's the reason. If you have an older male patient who have a little bit more horizontal heart, to the AVF, you could have a more pronounced T-wave inversion therapy. 20 years old lady heart with a big heart, most likely right ventricular. This is we don't know what's the etiology with this lady heart failure. I think look at the atrium. Atrium is not that big. Use some gigantic ventricle, both ventricles, very big. And I never seen it on cardiomyopathy like this, almost normal atrium on the ventricle. We don't have any etiologic diagnosis yet. This maybe I don't have a dynamic picture, unfortunately. It's everything still frame. So I think this lady most likely gonna need the transplant. I think we can fix this rhythm. What do you think, Dr. Do you think we can ablate this? So
That is what it is.
yeah, she failed amiodarone therapy and then she needed supportive care heart failure, but then she's 20 years old lady. She's what I found was informed that she's a law school student. But she's bright, but unfortunately, sadly, we cannot help her. Unless you go transplantation, charitable donation from I don't see. And after 2 months of heart failure treatment, he has to still remain 20%. Easy, left ventricular dimension, 60 minutes.
You bridge the transplantation, can we ablate the JT?
Oh, yeah, I think so. I think it may be even possibly to, sort of, she got some sort of a functional tachycardia or upper conduction tachycardia, maybe you can control the tachycardia just with CSP regulation. That would be, a potential option. So that's ask you that question. Can we ablate this? That is a. So I think she would be waiting for transplant, then we can do reason with the tachycardia ablation, CSP. That way rate will be controlled to this. That's something that get help it. But I think if you want to do that, we need to pretty good because she's very sick, not gonna last 2 months. Any other comment, anything that you want to add, please?
Does she have any visioning and MRI?
No, they don't have a good MRI in Cambodia. You cannot read it. Quality is. Maybe they have somewhere in private clinic, but I don't think anyone to carry MRI. They do, but we see in the MRI and quality there.
No genetic test.
No. They don't know, they're not even thinking about that yet, because what we told them, maybe to do that, because this is some rare single mutation, something. But
Is there some specific findings that only the female family members suffer from?
Right, grandma,
congenital
yeah,
heart
right.
attack? So I have experienced some mitochondria
What is
related,
this?
yeah, genetic.
Yeah, that's true.
genetic
Yes,
cardiomyopathy.
mitochondrial mutation, more common
Only
thing.
in both the female and
That is true. We did not think about that, we didn't talk about, it. But I don't know whether they did, that's what's with genetic testing. The mitochondria has been one of the hottest topic in basic science. Now. So you guys better start thinking about that.
Can I ask Dr. Hank schedule this patient? When will you visit Cambodia next time?
Oh, so once his lab is up, he will let us know. I told him call as soon as we get lab. If they are labs down because the amp is down, so we'll try to do something for her. Maybe we have to take a CSP with us and implant her. Something like that. So you guys still need to go to Cambodia, so it's pending, so that would be a great case to work with.
Dr. Teo Kim, for this patient, how will you manage it with CID? ICD, maybe ICD. Units ICD, right?
So primary prevention she does.
Yeah, but patient etiology is non-ischemic, but very high risk and very young age and if there is some time from treatment to heart transplantation, then it is reasonable. And if heart failure is aggravated and we already have planned to implant ICD, then CRT using CSP and also CS-lead, I mean, block CRT, LOT CRT can be tried if patient heart failure symptom persists, then yeah, we can manage with heart treatment. I think it is very sometimes very effective option. If patient have wide fluorescence and not typical LVB, right? LVB like morphology. So we need two lead, LVB lead and CS lead. LVB lead should not be just the receptor patient, but we must confirm LVB capture in this particular patient.
But that's fine, we simply finish the
I see the
Yeah. ICD CSP. And how do you think?
I have no opinion yet because I did not use and
I wonder, the cardiac MRI is mandatory before the implanting that kind of new procedure. Because if there is septal fibrosis, probably doesn't work.
I think if you're going to do, EP study of latest patient, this automatic slow related matter looking first that gotta come from conduction system. So then I think you have a very good idea, if you have some distant 3D mapping, what might be the patient side. You gotta play, then you can check the thresholds where things out there. They can use that back to guide the CSP and patient. So I think if you study ablation has two purposes, one is that ablate this AV rapid AV conduction catheter, whether atrioventricle or maybe both. Then also create this conduction system on both sides and guide it for them to insert the right spot. That's a good opportunity for people. Well, I'm looking forward to see when we can put a hand on this lady here. But transplant is not possible, so we hope that maybe combination of PTH ablation plus CST help them. Okay. Thank you. Great. All right, now we're gonna move to the EDM conference. EDM conference is very basic. We're not going to do a presentation today. Hopefully, I'm doing this because I want the fellows to recover. We don't feel like we are only the staff, right? Also busy. I'm the least busiest guy, so I'm